Hello, and welcome to a very special series I'm moderating on diversity, equity, and inclusivity by CME Outfitters. This is a CMEO briefcase called Take Action, Optimizing Equity in Gastroenterology Care. This program is supported by an educational grant provided by Johnson & Johnson. My name is Dr. Monica Peak, and I'm the Ellen H. Block Professor of Health Justice at the University of Chicago, where I also serve as the Vice Chair for Diversity, Equity, and Inclusion. I am a practicing internal medicine physician, as well as a health services researcher in health equity and a bioethicist. I've been practicing for about 20 years, and I really enjoy seeing the wide range of patients, including those who have gastrointestinal problems. And so I'm really delighted to be joined today by my very distinguished colleague, Dr. Nilanjan Nandi. Dr. Nandi, welcome to the program, and if you would please introduce yourself to the audience today.
Yes, thank you so much. I'm really pleased to be here. My name is Nilanjan Nandi. I'm an associate professor of clinical medicine at University of Pennsylvania, the Perelman School of Medicine, where I am blessed to specialize in the treatment and management of Crohn's and ulcerative colitis patients, collectively known as inflammatory bowel disease. I also happen to be one of the co-founders and chairman of the board for the South Asian IBD Alliance, also known as SIA, which is the first patient-physician collaborative and nonprofit dedicated to raising awareness and education and also accelerating research on IBD for all communities around the world.
That is wonderful. I was not aware of that. So we are very additionally grateful for your presence today. So you're bringing not only your clinical expertise, but a lot of the additional knowledge that you have with working with patients, not only as people that you see as patients, but also as people in the community as they're able to advocate for the very diseases that you work on in a collaborative fashion. So we're really looking forward to our conversation today.
Thank you.
Before we begin, I just want to note that this program is designed to build upon foundational concepts that have already been covered in some of our previous DEI activity series, and to learn more about the impact of systemic racism on healthcare and on health disparities, as well as how racial and ethnic disparities may present in the field of gastroenterology. We encourage you to engage in these foundational programs, which are linked here. So before we begin, I also just want to clarify that Nilanjan and I decided that we'd refer to each other by our first names in order to keep this session more collegial and just informal and friendly. And so Nilanjan, I look forward to our case discussion and our very candid conversation today. I'm going to start by reviewing our first learning objective for our program, which is to implement strategies to address inequities in the treatment and outcomes of patients with GI disorders. And we'll be focusing again today on inflammatory bowel disease. And so I'd first like to open the case with a question for the audience. And so the question is, how confident are you in your ability to identify racial and ethnic disparities in the management of patients with gastrointestinal disorders? Either not at all confident, somewhat confident, confident, or extremely confident. And of course, your answers are anonymous and confidential. So please feel free to just honestly answer. It helps us as a program to have a sense of how things are going. And so to highlight some of the disparities in the diagnosis and management of patients with inflammatory bowel disease, or IBD, let's consider a case example. And so Nilanjan, would you mind presenting the case of Dhanraj, whose pronouns are he and him, to the audience today?
Absolutely. Thank you, Monica. So to our audience, we have a patient named Dhanraj, whose pronouns are he and him. So Dhanraj is a 38-year-old South Asian male who immigrated from India 3 years ago to the United States. His primary native language is Gujarati, and he's been experiencing, when he comes to the physician, describing rectal bleeding, bowel urgency, and increased stool frequency. He does have a history of hemorrhoids, he notes. He works at a very well-known tech company and is very thankful and humble that he wasn't laid off on the recent rounds of layoffs because his visa is tied to his work. So this is obviously a stressor in his life. He's worried about his job because he frequently has to call out due to diarrhea, and he feels that his employer is already frustrated with his limited English proficiency. So, Dhanraj, I'm here in the Northeast United States, here in Philadelphia. We have a large, information technology enterprise and network here. So, I've seen patients just like Dhanraj in my clinic. And, the first thing that strikes me here is young South Asian male, has a history of hemorrhoids, which we'll talk about has some stigma in the
Mhm.
South Asian culture, in many cultures, right,
Right,
Monica? So many people find this taboo.
right.
Um, and he's really stressed because he's having these really disconcerting symptoms of rectal bleeding, which might be rectal outlet bleeding just purely from hemorrhoids, but it's really concerning that he's got the bowel urgency. Hemorrhoids really don't cause bowel urgency. That urgency, that sense of incomplete defecation, that's concerning for tenesmus, that there might be some swelling or proctitis, and that might be something like ulcerative proctitis or Crohn's proctitis. Who knows? We're not quite into the diagnostic stage yet. And then you see that there's this work stressor and life stressor, right? He needs to provide, he's got a job, his visa and job are tied together, and he doesn't want to upset his employer by being ill. So he's in a desperate situation, and that's the first thing that I'm recognizing, that he's not here begrudgingly. He's really concerned about his symptoms.
Yeah, and I think it's important that you've highlighted um, many of the sociocultural ways and pressures that people may have that keep them from either addressing their symptoms or being able to bring their symptoms to medical care. So they may want to just, there may not be able to, for social reasons, to sort of acknowledge that they have them, or
Right.
they may be
Right.
under such pressures to stay at their job and to work and to, stay in this country and can't take time off work or whatever, that they can't actually make it to the doctor. And so these are issues that translate to so many communities, and particularly in gastroenterology, or which is similar to urology or to, women's health, where the area of concern is a sensitive area that has a lot of an additional layer of sensitivity around it, that we can see some additional disparities just because of where the symptoms are coming from.
100%. And I just want to highlight, what you said so important about the social pressures of not speaking up. In almost every culture, we can relate that everyone poops, but people don't talk about it, right? And that's changing with modern times. In South Asian culture, and other cultures too, but South Asian culture I can speak for, people do not talk about their bowel habits. It's perceived as they don't talk about hemorrhoids. There's a shame in it. Although I'll tell you, as a gastroenterologist, I shine the light where the sun don't shine. Everybody has got hemorrhoids. Okay,
Mhm.
Monica. Everybody's got hemorrhoids, whether they know it or not, whether they've bled or not. And
Right.
in
I
South
see
Asia,
the
they call
reports from the colonoscopies.
that's right. That's right. And in South Asian culture, they call it piles. And it's something very stigmatized against in South Asian culture to even talk about blood and stool, or that something might be going on down there. But the other stressor here, his job and his visa, just to emphasize that point, this is a South Asian male who may be like sending money back home to his family, right, to support them. So he critically doesn't want to lose the job. He needs to keep the job, needs to keep his employer happy. So he's here under desperate circumstances. But anyways, I'm glad he came, and hopefully we can get more into the details of how to diagnose and then hopefully help this young man.
Absolutely. So we're going to ask the audience another question before we move on, and that's the question is having to do with diagnoses. And so, which of the following statements regarding disparities in inflammatory bowel disease is most accurate? That A, immigration status does not impact diagnosis of inflammatory bowel disease. B, patients born outside of the U.S. are less likely to be diagnosed before the age of 16 than patients born inside the U.S. Or C, South Asian patients living in Western countries are at lower risk of all types of IBD. Or last, D, patients born outside the U.S. and all underserved racial and ethnic groups are more likely to experience milder disease. And so for our audience, the answer is B. And so Nilanjan, would you mind just sort of walking through some of the information on disparities of diagnosis to highlight why this is the appropriate answer?
Absolutely. And, I like doing this type of, dissection of why these answers, some are right, some are wrong, because it
Yeah.
really impacts a whole lot more information. And so, we have studies that have done through the last several decades looking at IBD outcomes, prevalence, and incidence, and how it's changed over the last several decades. A couple of those highlights are that South Asian IBD, whether it be at Crohn's or ulcerative colitis, appears to be increasing in prevalence globally. And we know this through natural history studies. They actually do flexible sigmoidoscopies door to door to door. And they did that in northern India a couple of decades ago, actually in the 90s. And then they repeated that study later. And they saw that while looking door to door to door, they saw there was actually increasing prevalence, particularly in westernized cities.
Mm-hmm.
And we'll get more into why that may be. They've also looked at immigration pattern. When people from South Asia, migrate to the U.S. And to be clear, South Asia is actually 13 different countries beyond just India and Pakistan, but Bangladesh, Nepal, the Maldives, Sri Lanka, and more. There's almost 1.8 billion South Asians in the world, which is a significant chunk
That's a
of
lot
the
of
global
people.
population. And the prevalence of IBD in this community is estimated. It used to be estimated to be very low, but the studies are showing that in South Asian cultures and other ethnic minorities, that it's increasing. And in South Asian community, it seems to be almost on par as what we observe in European Caucasian populations here in the U.S.
Mm-hmm.
So anywhere from a minimum of 0.7% to as much as 1.2%. So Monica, I mean, 0.7% of 1.8 billion.
It's a lot of people.
That's a lot of people. That's a lot of people. And that's also a lot of people who don't know that they're at risk for inflammatory bowel disease. And to compound things, the traditional teaching, how I was taught in medical school, was that South Asians wouldn't have IBD. They weren't at risk for IBD.
Mm-hmm.
And I'll tell you, my own father was diagnosed with Crohn's in the 70s. It walked like a duck, quacked like a duck, but they said, you can't have it because you're a South Asian male. And someone took a chance, gave him some steroids, and sure enough, boom, just like that, he got better. So my what I'm painting to our audience here is there is an increasing prevalence of IBD. Patients are unaware that this exists because the symptoms can mimic so many other things.
Right.
And then clinicians, even South Asian clinicians, are maybe unaware that this prevalence is increasing. So with that framework in mind, now we look into the studies, and they show that a couple of different highlights, right? Those individuals who are born outside of the U.S., for instance, in South Asia, they're less likely to be diagnosed with IBD before the age of 16 than patients born in the U.S. So if you're native born here in the United States of America, you're more likely to present with IBD at a younger age. But if you were born outside and then immigrated here, you're more likely to diagnose it later in life. Now, part of that might be due to what age you immigrated, but beyond that, it seems to be a later age of presentation. We actually see similar things in the Latinx community, where those immigrating outside of the country coming to the U.S. are diagnosed 45 years and later, and those born, native born, are diagnosed in their teenage years, like 15, 16. Also, when we see patients who are born outside the U.S., they're more likely to be diagnosed with milder disease. And I'm going to put that in quotes because milder is a subjective thing.
Right.
Milder disease than severe disease, more likely to be diagnosed with ulcerative colitis compared to Crohn's. Although I'll get a little bit more detail there. When they're diagnosed with UC, it's more likely to be extensive pancolitis as opposed to proctitis. So although it may be in quotes mild by statistical demographics, there's more surface area involved. And that's a lot of colitis, and pancolitis usually behaves more worse than proctitis, right? And then when it's Crohn's disease, we actually see more perianal fistulizing Crohn's than just inflammatory Crohn's. And Monica, I'm sure you've seen your share of fistulizing Crohn's disease patients. That's one of the most devastating complications of Crohn's disease, right?
Yeah.
And then we also see that, South Asian patients living in Western countries are just in general at greater risk for all types of inflammatory bowel disease. That means not only Crohn's and ulcerative colitis, but remember, IBD is a spectrum. Some patients have a little bit of both, and we call that indeterminate colitis. As I mentioned, different ethnicities, Latin, Asian, Indian individuals may have more extensive disease progression than patients of other backgrounds. And this is a complete shift of what is published. This is different from the latest edition of textbooks of medicine that our medical students are learning. This is new data from the last 15, 20 years that's showing that these ethnic populations where we thought it was less common are actually more common than thought previously. And part of this, is because, misclassification, right, of racial ethnic, subtypes, right? When we fill out little questionnaires or census, it does not capture how diverse people are and how they identify, right, and what their actual ethnic origin is. Notably, and this is seen across, many patients of color, they do have reduced access to IBD specialty care than their white counterparts. And we'll get into this more, but that makes us pause for concern. Why would that be, right? Why would they have less access? And it's not an easy answer. One of it's multifactorial, but part of it is decreased knowledge, right? The stigma of having a chronic illness and what that says about them, right? In South Asian culture, there's this concept of karma, okay? You did this, so you deserve that, right? You didn't listen to me, so you deserve that. You ate that, so you deserve this, right? So there's that karma aspect, which may present with, social stigmatization and shame.
Mm-hmm.
And there's also, the family unit often tries to deter, in some communities and families, deter Western meds, but might say, why don't you try this Ayurvedic supplement or this herb, or why don't you do a dietary restriction? What these things do. Now, I'm not saying there's no benefit to them. There are some exceptions that we can get into, but what this often does is it delays the access. And in the meantime, the disease smolders and gets worse. And now they're a sicker patient than when they were first having symptoms. And then they get in to see a specialist.
Mm-hmm.
Notably, another thing, and this is true just in general, this is not just unique to South Asian culture, but 40% of IBD patients at large are actually diagnosed with obesity.
Mm-hmm.
And we've really changed the way we think about obesity in general, but 40% are obese. And we don't normally think, I'm saying we as a whole, don't normally think of it as
smaller people, malnutrition.
Malnourished, right? We're thinking emaciated, right? Cachectic. But in reality, obesity you can be malnourished and be obese. You can not be nutritionally replete and be obese. And in fact, obesity is in and of itself a systemic inflammatory state of being. The pro-inflammatory cascade is upregulated.
Diabetes, the metabolic syndrome.
The metabolic syndrome, exactly. And now we bring it back to South Asians specifically with that lens, and we know that South Asians do have a significant prevalence of metabolic disease, coronary disease, high blood pressure, diabetes, or insulin resistance. So all of these little teaching points are really important when you're seeing that IBD patient before you.
Mm-hmm. Fascinating. This could have been the whole session, but we've got so much more. So let's check back in with our patient and his case.
He comes in, we get his vitals. His blood pressure is 135/92, so not quite ideal, a little up, His heart rate's 98. Maybe he's nervous to see me. Maybe he's dehydrated. Tall guy, 5'9", 230 pounds. BMI is 34. We know that BMI is not a perfect metric, but, his BMI is quite elevated. So he would definitely be considered overweight. His primary care has tried to treat him with some antidiarrheals, right, to decrease the frequency of the stools, has administered a low FODMAP diet and education, and has given some hemorrhoid treatment, which has not helped. Ultimately, he ends up in the ER, and there he reports to the ER team that he's having fatigue, palpitations, abdominal pain, and cramping. And Monica, do you guys use a lot of FODMAP dietary counseling in your guys' clinic when you see patients in general with GI symptoms?
We do not. Tell me about it.
So FODMAP, and this is why I ask, because some people are aware of FODMAP, some are not, but FODMAP stands for fermentable. That's the key word. Oligosaccharide, disaccharide, monosaccharide, and polyols. A mouthful.
Yes.
But really, a fancy way of saying fermentable foods, fermentable compounds. Mm-hmm. And really, all of these are carbohydrates and complex sugars. And every food is made of these types of carbohydrates and sugars. There's no such thing as a zero FODMAP food. Right. And our gut is a big fermentation chamber, and our gut bacteria must digest the food and ferment it. And those byproducts can release gas and other substances that can cause loose stools or whatnot. And the bacteria must digest our food for us in order for humans to at all absorb that nutrition. If we didn't have gut bacteria, we were completely sterile gut, we would die, because we literally rely on our gut bacteria to perform the early digestion, not just our proteases and enzymes. We need gut flora to digest it and break it up so we can absorb it. So some foods are really highly fermentable, some are not fermentable as much, and they can create a lot of bloat and gas. Now, FODMAP has a great use in patients who have irritable bowel syndrome, particularly with a bloating predominance. They're distended. So you can give them a low FODMAP regimen where you identify high FODMAPs, take them out like onions, garlic, cruciferous vegetables like broccoli, cauliflower.
Yes, yes. So I've been doing that. I just didn't call it that.
Ah, there you go. And so, the running joke is we go get Mexican after this, and oh man, we know what's going to happen later, right? But everyone is sensitive to these things, and it's really useful in IBS. Now, it's brought up here because if this patient turns out to have IBD, we should know that up to 30 to 40% of IBD patients can have concomitant IBS. And bloating is a non-specific symptom, right? You can have it for a million reasons. It doesn't have to be from IBD. So there is some use. It's a restrictive diet, but it's not meant to be forever. If you restrict forever because you feel better on it, you're going to lose weight, be nutritionally depleted. So it's a temporary way of eating, but it's not meant for indefinite way of diet. And certainly the bleeding in the stools really doesn't go along with something totally benign like IBS.
Right. It's never benign.
Yeah.
It's not to have blood in your stool under any circumstances, really.
Yeah. Yeah.
That's always my take-home message. Alrighty. So yeah, everything is just so helpful that you're just a fountain of knowledge. So we're gonna loop back and ask the audience one more question, and this has to do with disparities in the treatment of IBD. So which of the following statements regarding disparities in the treatment of IBD is the most accurate? Is it A, patients born outside the U.S. are more likely to be prescribed immunosuppressants and biologics? B, South Asians with ulcerative colitis are less likely to show a trend towards steroid dependence? C, religion, cultural traditions, racial and caste discrimination, and socioeconomic status do not affect healthcare access or outcomes in patients with IBD? Or is it D, patients from underserved racial and ethnic populations experience more difficulty accessing specialists for IBD? We sort of showed our hand a little bit with our prior conversation.
Yeah.
And so for the audience, the answer is D. And so Nilanjan, I'm going to ask you to sort of maybe have a little bit briefer because we already talked about this a little bit, but discuss some of the data on the disparities in treatment in IBD and why D is the correct answer.
Absolutely. And so, I'm glad we discussed it early before getting to this question because it allows us to actually pause and then pick on some other points. I'm going to make light of this, but contrary to popular general stereotypes and beliefs, not all South Asians are doctors, lawyers, or engineers. And in fact, many fulfill all sorts of different jobs, non-traditional or traditional, whatever you might want to call it. I say that because sometimes this stereotype can actually work against someone who's perceived to be from that type of a culture that is stereotyped as high achieving, but not everyone is, not everyone can be, and that's okay. And I say that because that does not mean that all South Asians may have equal education or insight or literacy or even health literacy.
That's right. Two different things.
Yeah, right. And the other thing is when you see that South Asian patient, you want to get an assessment, right? In our case, Dhanraj is a very highly educated IT professional, right? But his health literacy may not be not so high. Most people may not have high health literacy, even if they're lawyers or physicists or whatnot.
Exactly. I'm very literate, but I'm only literate in the things that I know. Like I can't do anything else. My taxes, I have zero taxes.
Definitely not taxes. Can't do that. Yeah.
Zero literacy in everything else.
Yeah. And that's you're ahead of the curve because you're recognizing, right, that your patient may not be on the same page. And the other thing is, all patients, not just South Asian patients, are very polite and maybe nodding their head, but they're being overwhelmed with anxiety and symptoms. Remember, he's a little almost tachycardic there. So they may be listening to 10% of what you're asking and saying. So, we'll get into, language and communications, but you have to pause and ask them very often. Do you understand what I said? Do you have any questions? Can you repeat back what I said to capture their attention?
Exactly. The teach back method.
Teach back method. There you go. See, I didn't even know that's what it was called. So thank you. The other part of this is, we recognize he has significant symptoms impacting his quality of life, and he's concerned about his employment. He may be concerned about how he provides for his family here and also back home. You also must understand that we're not just having a conversation with a patient, even though there might be one other person in the room. Oftentimes in these communities, we're talking, the decision maker is not a patient-clinician decision making. It's a physician-clinician and a patient family unit.
Yes.
Whether they're standing in the room, I guarantee they're on the patient's shoulder or in their ear, and the patient's wondering, I got to talk to my family about that, or what will they think, and what, there are a million thoughts. And I think that's important because that can sometimes be what prevents that patient from taking the next step forward in terms of committing to a test or committing to a treatment or committing to a timely decision. Also, the last bullet point on the left was more worry about medication harm. In South Asian communities, there is a significant distrust. There's actually the paradox. There's significant respect for clinicians. They almost treat physicians as God back in the old country. But at the same time, there is a distrust of clinicians as well. So this paradox, right? Respect, but distrust. And in the West, when we come and immigrate here, that distrust is amplified with our Western culture. So recognize there might be distrust. Do you ever see that in your patients too, Monica?
Oh, absolutely. Yes. Yes.
And I think it's upon us, right, to try to engender that trust from the get-go, right, and say, hey, look, we're different. You can trust us. You can open up and talk to us. So
absolutely.
So
every
now,
physician is a messenger, is a representative, and so we want to do our best to stand as a bridge between the rest of the physician population and the patients that we're seeing.
That's right. That's right. Another thing to understand here in this is that because of the South Asian culture and our access to homeopathic or Ayurvedic therapies, which is a reference to medicines of homeopathy, which are microdosing, you can say, of certain supplements to impart effective treatment, and then Ayurveda, which is I'm surmising it very quickly, but utilizing natural or herbal or alternative therapies to treat symptoms and disease. These are often pursued upfront, early, and oftentimes well before a Western therapy or modern day therapy is initiated. And there are some exceptions in mild to moderate. You see high dose curcumin or turmeric. South Asians call it haldi, Haldi, with black pepper extract, is a very effective alternative and in milder UC. Okay, there's good data for that. And there are other supplements we can talk about too, but sometimes that is not appropriate or enough to quench the fire in that gut. And so that leads to delayed access to the actual drug. Likewise, because of what I talked about earlier, karma and social stigma, nervousness, poor health literacy, sometimes their job, that they may not be the doctor or engineer, they may not have a job that gives them good healthcare insurance, or so they don't have good access to a GI. And one of the travesties that I think in our healthcare system today is we know we have a complete dearth of all clinicians. We have a complete lack of enough primary care and family medicine specialists for the population at large. And we don't have enough subspecialists to actually service on a population-based health scale all the patients that we have.
Right.
And so when you have niche care in an IBD specialist, not just a GI, the wait times to get in are even longer, right? Fortunately, the GIs that we see today, they're even better educated. Some of the ones who are attending this, they attend conferences, they're learning, they're hungry for this knowledge. And so you don't have to go to an IBD specialist to get this. But again, because we don't have enough GI specialists for the population at large, there's still a long wait time and delay to get in early when it matters the most. Some of the other teaching points on this slide are that South Asian patients with UC seem to trend with higher rates of steroid dependence and also C. diff. Now, to break that up, having any form of IBD is an increased risk factor for C. diff without antibiotics. Without antibiotics, you can get it, and you're more likely to have recurrent refractory C. diff. And as far as steroid dependence, we don't know why there's more steroid dependence, especially if they have pancreatitis with mild disease. Is it, and this is a question, I don't know the answer, is it because there's a delay in care and a delay to effective therapy?
Right.
I think those are possible. And then, of course, we talked about throughout this, the cultural competency aspect. We're not recognizing that there may be barriers presented by the patient's immigration status, their gender, or even their religion that may prevent barriers too.
So lots of things, so many things to consider. So let's take it back to our case and pick up where we left off with learning some of the information about our patient.
Okay. So one of my favorite, if I have a favorite stool marker, I'm that guy who has a favorite test in IBD. It's calprotectin, stool calprotectin. Yes. Stool calprotectin is an inflammatory marker found in neutrophils. It's more sensitive for colonic disease than small intestinal disease. So it's very good for colonic disease. So great for a patient who has any type of Crohn's or ulcerative colitis. Normal's less than 50, elevated is more than 120. His is 400. It's elevated. It's not crazy. Crazy is like, significance like thousands,
Mm-hmm.
but it's elevated. You note that looking at his hemoglobin and iron indices, he has a severe microcytic anemia, hemoglobin 8, MCV 72, with a very low iron sat, 7%, and a ferritin at 12. So looking at World Health Organization criteria for men and women, this is severe iron deficiency anemia. He tells you he's got blood loss, visual blood loss, which might be contributing to it, but also IBD, just the inflammatory state of IBD actually presents with anemia of chronic disease. So you have high hepcidin, which downregulates ferroportin in the duodenum, so you're not absorbing iron, and so you end up becoming iron deficient. And that can happen even if you're not having more severe overt blood loss. So iron deficient. A CAT scan in the ER shows circumferential symmetrical wall thickening with fold enlargement. That is consistent with UC. And his subsequent colonoscopy shows that this gentleman has endoscopic findings that essentially show he's got Mayo 2 ulcerative proctosigmoiditis. And so we should entertain a discussion of all the different therapies now, but probably pause to check in with him before we go further into what kinds of treatments we're going to discuss with him.
Yes. All right. And so once again, we're going to take a little quick pause and check in with our audience. So given his lab values and the assessment that we already have, what treatment option would be the most appropriate for this patient? And so option A, mesalamine, for those who've been practicing for a while, we remember that, and long-term glucocorticoids, oral mesalamine therapy, so not topical, thiopurine monotherapy, or D, early treatment using biologic agents or small molecule agents. And so you might guess that we are now in a new stage of medicine, and so we're going to do D, using biological agents. And so Nilanjan, can you walk us through why D is the best option?
Absolutely. So, in this gentleman, we have multiple options. In terms of inflammatory bowel disease, we have 6 different categories, 6 different mechanisms of action for treating inflammatory bowel disease, particularly if this happens to be a UC patient, which we believe it is. And they're all not created equal. We have small molecules, which are pills small enough to be absorbed, and large molecules, which cannot be absorbed orally, have to be injected. And we have multiple novel agents, and almost every generation seems to have advantages. We have anti-IL-23 agents, which are relatively new, in quotes, to the IBD world, but have long history of safety data in other disciplines, derm and rheum. We have IL-12/23 agents, anti-integrins, anti-TNF therapy. Those are our biologics. And we have different ways of placing these, right? Anti-TNFs, about a third of patients may develop antibodies and lose response, but the more modern day biologics don't have that high neutralizing antibody effect. So IL-23s are very effective. Anti-integrins and IL-12/23s are also effective. And there's still a place for the TNFs. There's 2 classes of small molecules. One class are called JAK inhibitors, and one class are called S1Ps. Now, this is very intimidating for anybody to imbibe. The main barrier here, though, is education and overcoming fears, primarily the same ones that you and I would be afraid of if we were in their shoes, like cancer, infection, and the stigma of a chemotherapy, because that's how it's billed on insurance, if it's an IV medicine, or taking a chronic medicine that you're chronically ill. This can affect how patients are perceived by their families, your marriageability, unfortunately. And so people will say,
I haven't thought about that.
Yeah, who's going to marry you now? Don't tell someone don't tell that fiance or that partner that you have this, or don't tell their family. What will they think? So multiple reasons, but we need to be thinking about definitive therapies. If that patient has Mayo 2 moderate disease and they don't do well in mesalamine oral rectal, then you should try them on an advanced therapy early and take advantage of these new agents that we have early. Now, when it comes to disparities in outcomes, we have, South Asian patients are reluctant to enroll, as many ethnic minorities are, mainly because of fear of a clinical trial, misconceptions that they might get placebo, that they're an experiment, when in fact, most arms of a study actually result in getting the actual medicine, and you get even superior care because you're being supervised very, very frequently. Things that we underestimate, Monica, are the impact of diet. Much of the dietary information about IBD is not customized to the cuisine of the South Asian patient or the other ethnic minority patient, right? How do you eat dal or roti, high fiber foods? How can you change these things? How, if I get bloated with dairy, with my yogurt, also known as dahi, is there an alternative that I can eat in my diet, right? So we need to customize dietary practices. And then, of course, this poor disease awareness amongst the community of patients and the community of clinicians at large, including South Asian clinicians, that IBD is present in the South Asian population. And then based on financial income, sometimes there's significant heterogeneity in affordability of these drugs.
So thank you so much for all of that. Again, just a fountain of knowledge. So this brings us to our second learning objective, which is to implement actionable strategies to improve health equity in our own practices. And so we're going to kick it off once again with an audience response question. And so this has to do with our social drivers of health. And so again, as we start a section, we're going to just ask about your confidence in dealing with these issues. So how confident are you, our audience, in your ability to utilize an appropriate social drivers of health screening tool that considers cultural traditions, religious preferences, and other drivers of health when caring for patients with IBD? And so is that not at all confident, somewhat confident, confident, or extremely confident? All right, and so then to help our audience with actionable strategies to improve the equity for our patients, I think it's sometimes important to first consider the impact of IBD through the racial and ethnic lens of patients. And Nilanjan, you've been doing an excellent job of sort of creating this narrative storyline of patients from South Asian cultures to really I think help us sort of get into the home life and the family life of what that might mean. But can you just give us some additional insights that would be helpful for our viewers to sort of better understand some of the barriers that our patients may be facing?
Yeah, absolutely. This next slide, which is quotes taken from a qualitative study in IBD patients, was conducted by Professor Mukherjee in the UK. And she looked at a series of South Asian patients and interviewed them one-on-one. And some of these quotes really are powerful. And I won't read through every single one of them. Our audience can look at them. But some of them, the top left one talks about, spiciness of food and how the patient's not reacting well because they have active disease, but their mother is not understanding, oh, why are you not eating my food? Why is it uncomfortable for you? In the top right, I think the biggest problem will be some people will not be able to differentiate from their religion to medicine. They just can't seem to see why this food is breathtakingly bad for me. Again, another one focused on diet. And patients know themselves and what's going to agree or disagree, but yet there's this cultural pressure like eat, eat, eat this, eat that, you'll be fine, right? And then the bottom left, this is really important. We clean ourselves in a different way because of our religion. I was suffering from diarrhea and it put a lot of fear on me. It would probably prevent me from going out for long periods of time. It's talking about the hygiene aspect, right? And, there's a particular focus in many communities and religions and cultures of cleanliness and hygiene, yes, right? Cleanliness is next to godliness, right? Yes. And if you're at the local temple and you have to go to the bathroom often, people are wondering, oh, are they clean? Are they going back and forth? Are they emptying their ostomy bag? What is going on? Is this dirty? Okay. We often are told, eat with your right, clean with your left, because we squat and wash ourselves. If we're in South Asia, here that doesn't really happen in the West, but it's the same cultural impact of your left hand might be dirty. Okay. And so this also, if that's how you participate or engage with your hands in a religious ceremony or service. And then also, I can't speak English with the white doctor. Sometimes an interpreter is at the appointment, but for the past 3 or 4 appointments, no one was booked. And that's unfortunate. Even with all the interpreters and access to language and technology, this patient doesn't have someone that they brought with them to speak the language, to navigate the language barrier. We should really be going whatever we can do to help navigate that and make sure we have someone who can translate. So diet, hygiene, and language barriers. These are very common themes and obstacles to just great communication, acceptance, and building trust with the patient to get to their care.
Excellent examples. And really just so powerful in how people's cultural identity and their practices that are necessary for them being part of that community can be barriers to maintaining good health. And how do you prioritize one over the other? And so, unless you know about these and can actively engage the entire family in understanding and having strategies, then
Yeah.
people may be making choices, really difficult choices, that may put their health at risk. So, Nilanjan, you just gave some great examples of how all of these sort of weave in and out of people's lives. Is there a way that we can sort of, as scientists and clinicians, think about this in different kind of buckets as far as social drivers of health and how we may be, we're used to having mnemonics or sort of running lists and think about things that we want to make sure that we've checked off in our own head as we're thinking about barriers or issues that we need to be addressing for people who have inflammatory bowel disease.
Yeah. Monica, I love how you asked that. You said, how can we as like scientists and clinicians tackle this? Because it's a very intimidating problem, cultural competency. It's not something we teach well, and it's not something learned overnight, right? It's something practiced. The good thing is we can break this up into buckets. We can break this into upstream drivers, midstream, and downstream drivers or consequences of how we can break up and identify which social determinants of health we can intervene upon. So we've kind of talked through them a bit. Upstream drivers in the beginning, don't assume health literacy, but get to know the individual patient without assumptions about how their culture impacts decision making. What is their health literacy, not just literacy, general literacy? What is their income status and access to health care? And how does their gender affect their decision-making capacity? And is it just them making the decision, or is it a family unit? Okay. And then of course the financial aspects determine transportation and just basic things like that, or talking on the phone. Midstream drivers are really important, and these are hard to tackle, but the more you do this, you can seamlessly gather all this information in that first visit. But you can understand, what is their social support? Do they have a significant other or a bestie? And if not, who can service that? Oftentimes, if someone says they don't have someone they can trust or talk to, I ask if they happen to be a spiritual or have a person or have a religious faith they subscribe to. Do you have a priest? Do you have a pandit? Do you have an imam? Do you have someone that can help you with these decisions that I can speak to on your behalf, or even translate?
Yes.
And then of course dietary barriers in the South Asian community. There are many South Asian dietitians now. They are accessible in person, and oftentimes through the magic of televideo. And so there's really no reason that you can't find a South Asian dietitian. They exist. And then of course with the language proficiency, again, telehealth. If you schedule a translator in advance, they show up, and then you don't have to worry about not being able to speak to the patient. The outcome of all this is, if we do not assess these factors, there's downstream consequences. And that means the patients don't get the right treatment. They do worse. They flare. They need steroids to go to the emergency room. They may perforate. They may bleed excessively, have anemia and associated complications. They may need surgery emergently, and you never want to do emergent surgery. So the downstream consequences of not tackling this upfront and early are a heck of a challenge for us to manage, and far worse for the patient to endure.
Mm-hmm. Absolutely. Absolutely. So, speaking about patients, let's go back to our patient case and see how he's doing.
Yeah, so Dhanraj undergoes this social determinants of health screening from his GI, because they watched this series and the modules and learned how to practice and get good at this. And we learned that he happens to be Muslim. He observes Ramadan, where there's a lot of fasting throughout the daytime hours, which can affect his nutrition and nutritional status, and so we have to be aware of that. He keeps halal. He is very interested in discussing cultural food choices and preferences that limit his engagement with FODMAP, which is not a diet that we recommend in IBD specifically, but IBS, but may help him get through a flare. And although we can give recommendations, most of us clinicians are not dietitians, and I always say refer to a dietitian, because that is their career. That is their high education level. They're very good at what they do. I can't do dietary guidance like they can. And if you can find a South Asian dietitian, even better.
Matter.
And then we identified the financial barriers, right? We talked about his visa status, but he currently has Medicaid, which can present difficulty with insurance access and authorization. It may narrow down some of his medication selection and affordability. They may cost a lot of money. And because of his limited English proficiency, he may not be able to complete the paperwork without assistance, even though he's a very highly intelligent gentleman, right? So these are the things that we've learned by interviewing him and sitting down and thinking globally.
And so those are things that wouldn't have necessarily jumped out at us when he just walked into the room, looking as he does as um, professional in the tech industry. And so now that we've screened for some of these things, what are some of the actionable strategies that our healthcare team can take to sort of help improve the outcomes and have him live his best life?
And so this is the right. You just said live his best life, right? So we can be very good at discussing treatment, but if this barrier is in the room, there's no treatment going to be had.
Mm-hmm.
And so actionable things are, case managers and social workers can be established. He came to the ER. That sucks, but you know what? Let's utilize the ER in the hospital and its glorious resources and get him a social worker and a case manager. They're profoundly valuable, and that can happen right there. So if you're not sure how to get one, remember an ER is an opportunity as access to healthcare resources in that patient's community. Ensuring interpreter services are present. We talked about dietary referrals to a dietitian who's culturally inclined to cater to that patient's dietary preferences. I say don't call them restrictions because there's a stigma against that. It's a choice. Their preference is really important. So
Yeah,
remember, words matter.
we do.
And then also, obtaining community support, and that could be a patient navigator, or like I said, oftentimes South Asian individuals, not all, have a local religious, faith member who's more than willing, to be of service to that patient. And then also we can consider engaging that patient with online support communities. So for instance, I mentioned I'm very blessed to be a part of a beautiful community known as the South Asian IBD Alliance, which is a global network of physicians and patients on our board. And we do outreach and education to patients and their caregivers through Facebook live streams with professors from across the globe with patients on one chat talking about IBD 101, medication, sexuality, dietary therapies, vaccines, and what this means, what's the stigma, how do we overcome it. We also do community education to clinicians, actually CME for clinicians in the IBD space, educating them on this and developing digital resources and tools that they can use, you can use to teach patients and overcome these barriers. And then we actually have a research pipeline where we've published qualitative research studies, and also we are doing clinical translational research too that's in the works as well, trying to accelerate IBD research. SouthAsianIBD.org. That is SouthAsianIBD.org or SIA. That is the website. And there's a Facebook community of 1,800 South Asian IBD patients moderated where they can get community and know, gosh, I thought I was the only South Asian. Nope, I'm not the only one. There's also the Crohn's and Colitis Foundation of America. And there's also other community organizations that are nonprofits that focus on other aspects. Girls with Guts in terms of women's health, 18 and up nonprofit for IBD, IBD moms for pregnant mothers or mothers who are already moms who are trying to navigate the IBD space, but also participate in engaging in cultural competency. So there's no shortage of resources. You just have to know that they exist. And so I am biased that SIA is a very good nonprofit that can get access to these types of education for patients.
Thank you so much. You're such a wonderful ambassador, not just with your own knowledge, but again, with the work that you're doing in the community. And so thank you for sharing the website information and all the ways that we can link in and plug into your own organization. And just for talking to us about what is so critical nowadays, the idea of a team-based approach for addressing chronic medical diseases. And so as a primary care provider, that's all I talk about is team-based care, because physicians cannot do it alone. We have to have an entire team of our dietitians, our community health workers, are working with our specialists, our case managers, our behavioral specialists, all of those things. And so patients enter our healthcare spaces through lots of doors. There's no wrong door. They may come in through the emergency room or the inpatient, or they may make an appointment as an outpatient. But all of these are ways that they can find their way to us and access all the different services that are available for them, so they can again begin to live their best life. And so I just want to remind our audience the team that addressed Don Rogers' healthcare needs. And so that was the dietitian, all the different kinds of community support, the interpreter services, the GI specialists, of course, and the case managers. And then just some sort of like take-home ideas is that for us as clinicians, that we need to lean in to our patients and their cultural beliefs and ideas, how important that is, that sort of through line narrative throughout our session today, to understanding what patients are doing, what they're willing to do, and how closely and integrally related that is to their healthcare plan. Our healthcare plan has to align with patients' social and cultural plan, and that we need to create a safe space for patients to be able to talk about those things. If it's not a safe space, they're not going to share it with us, and then the plan that we have is going to be incomplete. We need to be able to create these safe spaces so that we can ask our patients about some of the social drivers that are impacting their health, so that we can help fill the care gaps. We may not know that they have challenges paying for their medications. Some of these medications for the biologics are really costly. Not everyone has excellent coverage for some of those. They may need additional help with case managers or interpreters. And so having honest conversations about what people need is going to be critical. And then setting goals with patients. All of what we've been talking about is essentially what I study all the time and think about, and I'm such a proud advocate for, is the idea of shared decision making. We don't make decisions for our patients. We make decisions with our patients that respects the desires and wishes, dreams, goals of them and their families for them to live their best lives. And so with that, Nilanjan, is there anything that I've missed that are big picture points that you want to make sure that you underscore for our audience today?
I thought you did an amazing job right now, kind of highlighting this approach. I think the most important thing is that while we're talking about a South Asian community here, a lot of these ideas translate to all different cultures. We just have to customize it. And I think that we often ask ourselves as clinicians, why isn't that patient adherent? Why are they taking so long to make that decision? And it's often not the medical decision making only, it's the factors that influence it, like what are their fears, concerns, obstacles? If you spend more time asking them about these factors, you will make more headway. You will actually gain trust. And the patients and their families will understand that you're hearing them, and you can begin to start reassuring them, because they're not distrusting you. You're breaking that wall down. They're trusting you. And now you can help that patient move forward. A lot of what we do as clinicians, the treatment, there's an art to that. But you can't even discuss treatment until you break down these cultural barriers and get them. Now you're talking. Now you're having a conversation.
That's right. That's exactly right. So we spent most of today sort of on the case study of the South Asian population, but every population is unique and different with their own sort of beauty, and we need to be able to engage with every population that we see, and they're all going to have their own barriers, their own way of living, their own way of doing things that we have to create spaces for, and figure out ways that we can adjust the plans for those patients that are coming to our office, and be ready to welcome them with love and open arms and an open mind. And so I have, I think, maybe two final audience response questions, mainly about confidence. And I'm hoping that your confidence has improved with your ability to sort of care for some of our patients. The first one is, how confident are you now in your ability to identify racial and ethnic disparities in the management of patients with gastrointestinal disorders? Not at all confident, somewhat confident, confident, or extremely confident. And then our last question is, now, how confident are you in your ability to utilize an appropriate social determinants of health screening that considers cultural traditions, religious preferences, and other drivers of health when specifically caring for patients with IBD? not at all confident, somewhat confident, confident, or extremely confident. All right. So Nilanjan, this was such an excellent discussion.
Thank
Cannot
you,
thank you
Monica.
enough. I'm going to try and summarize again with SMART goals. And SMART goals are ones that are specific, measurable, attainable, relevant, and timely. And that's what I hope that our audience takes away from our discussion today, your wonderful presentation, and can apply to their very own practices. So first, to identify disparities in the diagnosis and treatment of IBD. Next, to identify the impact of disparities related to immigration status, race and ethnicity, and cultural traditions in IBD. Third, to integrate holistic treatment strategies, including screening for social drivers, into the care of patients with IBD in order to improve equity in treatment outcomes. And then last, to consider team-based strategies in the care of patients with IBD to address inequities in the treatment outcomes. So this CMEO briefcase is just one of a 4-part CME CE initiative, and we really hope that you'll take advantage of all of the parts and participate in all the activities in this series. We cover a number of strategies that address racial and ethnic disparities across therapeutic areas, and I really encourage you to join us for the entire initiative. It's going to be so much fun. By participating in these activities, you'll demonstrate your own commitment to improving health equity for all of the patients. The CMEO D&I Hub also has a number of resources that are available to help you further your own personal education on diversity, equity, and inclusivity. And so, Nilanjan, I'm just going to end by thanking you again. What a pleasure joining us for such a robust conversation.
Thank you for having me, Monica. I really appreciate the opportunity.
You're just a blessing. Just continue all the good stuff that you're doing. It really is a wonder, and you're just amazing. So thank you for all that you do for all of your patients, and specifically providing a carve out of a safe space for the South Asian population who has inflammatory bowel disease. All the extra work that you do that you're not getting paid for in your free time with patient advocacy and all of those things. All of it means so much. And so thank you, thank you, thank you.
Thank you.
So to receive credit for this activity, please complete the post-test and evaluation. We do this so that we can learn about how we're doing and be better. So we really appreciate this feedback. Tell us what you like, how we can improve, and what additional topics you'd like for us to address. And so I just really want to sincerely thank you, our audience, for your commitment to diversity, equity, and inclusivity education, because together, all together, we can strive to provide the best and most equitable care to all of our patients, particularly those who are most marginalized and underserved. Thank you for joining us.